investigators throughout the world and share with you part of some of my translational research that I'm performing at the Chemo Cancer Center Radiation at Thomas Jefferson University in Philadelphia. So despite of all the efforts that we do, all of us, cancer has still remained the most formidable disease of the mankind. Every minute in the United States, throughout the world, we lose more than 15 people every minute of cancer. That is one death for every 4 seconds. In the United States alone, despite of nearly $10 billion of funding spent on cancer research, we still lose one individual at every 30 seconds. This obviously has to stop, and that's why we all are here. So with that, I'm going to focus for this presentation for prostate cancer, what I'm contributing along all of you to minimize the number of mortalities perhaps and to misery that the causes to the patients in each case. Prostate is an organ that sits quite below the bladder in male, very heterogeneous in this occurrence in this presentation, as well as very heterogeneous in biochemistry of the cancer, as well as histology. And that makes it extremely difficult with the prostate cancer diagnosis as well as the treatment. 17% of all the diseases, cancer diseases that are caused are due to prostate cancer. Very slow growing, as we all know, heterogeneous disease in biochemistry, etc. In the United States alone, estimated in 2015, more than 220 patients, 13% of all cancers will be due to prostate cancer. Prevalence last year in the United States is nearly 3 million men are living with prostate cancer without any regression of the prostate cancer. I will come to the DRE, digital rectal examination, and PSR, that are the screening tests that remain most viable for prostate cancer today. But there are obviously some problems which will let you know what these DRCs are doing. So continuing with the prostate cancer, there is a 17% of probability in lifetime for all men that are sitting here and in the rest of the world will be victim of prostate cancer, and then eventually 3% of them will die out of prostate cancer alone. The most diagnosis age for prostate cancer is average to 68 years, and the death averages at 80 years. Every 2 minutes in America, prostate cancer is diagnosed, every one person. And every 18 minutes, a man dies of prostate cancer. Very sad when we think of it. And that's what promotes us or encourages us to do what we are doing to minimize this mortality and the misery of this patient. Unfortunately, so as the age grows and we continue to live longer, there are going to be more and more prostate cancer patients. In 2015, it is estimated, now we take 13% of those, nearly 30 million people, that's 1.3 million people are going to be every year diagnosed with prostate cancer. So as Professor Omura just mentioned, screening of the disease is very important. And it is in Business Week, such a magazine that we read, so there is a more and more awareness of screening for prostate cancer. And Dr. Omura demonstrated us in the coffee break, very intriguing the way he calculates the negative charge and a positive charge. We are not there yet, but I think we are scientifically trying to understand more and more of it and try to provide the screening processes for all the diseases. And we're going to concentrate here for the screening of prostate cancer. Now, In 2004, United Kingdom National Screening Committee defined what the screening process is. And if I read you the systematic applications of a test or inquiry to identify individuals of sufficient risk of a specific disorder to warrant further investigation or direct preventive action amongst persons who have not sought medical attention or accounted for of the symptoms in that disorder. Well, when I was reading it, well, these are British people, their English is much better than ours, so I simplified it for us. The testing is an asymptomatic patient for an early detection of disease. I think that's a very simple thing to remember, testing an asymptomatic patient for an early detection of disease. So what are we doing in that definition for prostate cancer? There are three common tests that are used today. One is very well known to all of us here in the audience, called PCA, prostate-specific antigen. Another one is DRE, digital rectal examination, and this is a new test that was just approved about a year or so ago by FDA. It's called PCA3 score. PCA3 is a gene, and that is the detection of that. We'll briefly talk about the positives and pros and cons of those, and then lead to what I'm trying to do to simplify some of these tests. So PSA is a 33 kilodalton protein. It comes to a family of granular alkene peptidase. It's located at the 19 accuse of the gene KKL3, androgen regulated. But the good thing about it, or bad thing about it, is that PCA half-life is only 2 to 3 days, and free PCA disease lasts only 2 to 3 hours, and excretes via renal disease. PCA is normally done from the blood cancer, and if you look at this data, only if 10 to the power of 6-fold higher in the seminal fluid, that PCA protein, and it's only 0.6 nanogram per milliliter is mediated to serum level. That's why the PCA unit is very, very small to measure, and although it is sensitive, it's very small to measure, and that creates additional problems to it. So it remains free in the blood. Sometimes it's also complex with proteases, inhibitors, several isoforms of the protein form, and interacts with, or sometimes it's nicked or fragmented, which also makes it difficult to understand. PCA is ordered most of the time, 65% of the time, by internal medicine physician, 24% of the time by family medicine, because that is easier test to perform. But when you look at the data, nearly 30 million PSAs are tested performed per year, and this is in the United States alone. And only about 3% or 4% of those can truly benefit by that PCA test, by a variety of different reasons for which we do not have time for. If you have 30 million biopsies are performed, only about 220,000 people get diagnosed with this. So there is a controversial data on this, and as these days, any patient, any male 70 years or old knows any reputable organization, medical organization, proposes that the PCA be performed on that 70-year-old patient, because it's very insensitive and non-specific. 6% of the men who are 40 with no symptom of it have PSA level of 4 milligram. And generally, urologists will perform not only DRE, but also sometimes biopsy, and I'll talk about that, if the PSA is persistent over 3 or 3.5 nanogram. So it's not very specific test, and that's why it has not been organized more. And as I said, it finds only 3% of the cases correctly, and many of the patients it doesn't help. So the PCA3 DRE, I will come to that later. The PCA3 is a very clever test. It counts gene from the shed urine. It requires DRE, so you can palpate and stimulate the prostate to express the PCA3 from that. Urine is collected, and the PCA3 is performed. In the next slide, so it's very complex test, takes a lot of time, effort, cost about $3,000 per test, and yet if you look at the results, the sensitivity of this test is either as little as 47 in 463 patient study data showed to no more than 87%, and the specificity is even less than that. So many of the urologists in the United States do not order this PCA test. So what are we left with? We do not have PCA3, we cannot do DRE because DRE shows it allows, DRE allows only aggressive enlargement, assesses only enlargement, but cannot really determine the foci of PC because unless they are on the surface. So we really do not have a proper screening tool. So the physicians although say the urologist, well, PSA and the newer biomarkers are not good, so our rectal examination is better. But what they really want to do, like to do then, is to do the biopsy. The biopsy, as you can see, is very torturous. 12 samples are done by putting the ultrasound detector and the needle that then punctures and take these 12 biopsies from the patient. Again, to find, although greater than 1.5 million patients biopsies are performed, these find benign pathology at the expense of the patients and their morbidity, and billions of dollars, healthcare dollars are wasted by this DRE because we do not have any other better technique. There was an article just two days or 3 days ago in the United States that estimated $4 billion are wasted on these biopsies every year on this patient because it is very hard for a physician. If you can imagine that the prostate cancer, as we saw earlier, heterogeneous, little glanule here, little glanule there, it's very difficult to find that, where to get that biopsy. So most of these biopsy miss that, and they find sometimes so that's where the problem is coming from. So what can we do? So people like ourselves think and see. So most of the approaches these days on the drug discovery have been focused upon better understanding of the biological pathways that govern the genesis of disease at a molecular level. Doing this, many counterparts of mine in the world have developed several of these agents, and I have taken a slightly different approach that to look at the oncogenesis of the disease itself and what the biochemical changes that prompts that disease to occur. So when the biochemical changes performed by a variety of different molecular ways, various genes are performed. P53 was mentioned earlier in most of the cancers, cancer preventive disease gene, and also on the surface there are a variety of biomarkers that are expressed at the oncogenesis of disease. One of them that I'm targeting is called VPAC1. VPAC1 I'll tell you what the VPAC1, but at the